Hello, welcome. My name is Louise Cohen. I'm the CEO of the Primary Care Development Corporation, and this is our annual Primary Care Summit, where we focus on issues relevant to primary care practice and policy. And this year's topic is closing the equity gap, intentional investing in primary care. And we have with us today two wonderful primary care champions we'll introduce in a minute. Just to let you know, the Primary Care Development Corporation is a not-for-profit community development financial institution, which is dedicated to primary care and health equity. And we believe that primary care is really the heart of the healthcare system. Primary care offers a lot, and the research is comprehensive and clear about its benefits. It improves health outcomes, it reduces hospital and emergency room visits, it improves life expectancy, it reduces all-cause mortality and maternal, infant, and neonatal mortality. It creates good jobs and is an anchor institution in many communities. It reduces the total cost of care, and it improves health equity. And by that, we mean health equity both in access to services, to healthcare services, and equity in health outcomes. And a lot is expected of primary care at this point in time. We talk about primary care as being patient-centered, culturally competent, and appropriate, easily accessible in the office, by phone, and certainly now with other kinds of technological means, telemedicine. Primary care providers are expected to provide anticipatory guidance, shepherd children through their developmental years, provide preventive services for children, teens, and adults, provide screening to avoid chronic diseases from developing, and to provide care to keep them from progressing. And of course, vaccination across the life cycle. So all the childhood vaccinations, whether it's measles, mumps, and rubella, or the flu vaccination, or COVID vaccination. This is a critical component of what primary care providers do. And primary care providers are expected to coordinate with community resources, supporting transitions of care, aligning with other parts of the healthcare system, and identifying and addressing other concerns that really impact people's health that we know about, such as housing, food insecurity, and poverty. And primary care is central to reducing premature mortality and helping older adults live as independently as possible for as long as possible. And so in this light, it's easy to see why our organization considers access to this kind of primary care to be a social determinant of health. And we believe that many primary care providers are working hard to provide this kind of care in their communities. But for all of this work, primary care gets about 5 to 7 cents on the healthcare dollar. And this lack of investment holds back the ability of primary care to be successful. And we think that the question of how primary care fits into the healthcare financial ecosystem, in other words, how we think about investing in primary care, is essential for our society to debate and decide. And we hope that today's conversation is part of thinking through the way forward. With that said, we will have a conversation with two women who are primary care champions and who are working to achieve health equity in healthcare and public health. So let's just get started and jump in. So I'd like to ask each of our panelists to briefly introduce themselves, and then we'll move into the discussion. So first, Dr. Charlene Wong, who's the Assistant Secretary for Children and Families at the North Carolina Department of Health and Human Services. Welcome.
Thank you so much. So pleased to be here. So I am a practicing primary care pediatrician. I specialize in adolescent and young adult medicine. And what really drew me to primary care in the first place was really being able to have these longitudinal relationships with these teens and young adults, getting to see kids who are thriving, getting to work with kids who are not thriving, and really working with them to get them back on that track of thriving. In my role as Assistant Secretary for Children and Families, I'm really working with a wonderful team at the North Carolina Department of Health and Human Services to think about how we can do even more so that we can improve child and family well-being, so that all children, and Louise really gets to that thought of equity there, all children have the opportunity to develop their full potential and thrive. I'm really thrilled to be here today and talk more about how we can infuse and lead with more equity as we think about primary care and the important role that it plays in the health and well-being of all people.
Great, thank you. We're glad that you're here. And now I'd like to ask Shelina Davis, who's the Chief Executive Officer of the Louisiana Public Health Institute, to introduce herself.
Thank you so much, Louise, and thanks so much for having me here today. I'm Shelina Davis, the CEO of the Louisiana Public Health Institute, also a public health social worker by training, and like to kind of liken myself as a health equity ambassador and kind of weave that and center equity and justice into all the work that I do. At the Louisiana Public Health Institute, we are a statewide community-focused nonprofit organization that leads and partners with communities and organizations to ensure that all Louisianans and people here in Louisiana have fair and just opportunities to be healthy and well. We work on many different programs, about 70 to 100 in a given year, on all the array of public health topics, including working very closely with our dear friends who focus on primary care and prevention. So definitely looking forward to sharing more today.
Good to have you both here. So let's just jump into the conversation. We all know, you all are clearly well-versed in this, that health and well-being is multidimensional. It's formed over our lifetimes. It's impacted by social and racial, emotional, economic, and environmental conditions. So I'd be really interested in having you tell us a little bit about your experience in your state or other experiences that you've had around the country to say, are there really robust examples of primary care anchored systems of care that address the whole person and think about really whole community health or population health? So why don't we start with you, Shelina? Why don't you tell us where you think or what you think are glimpses of where we might find that primary care anchored systems?
So I start by saying when I think about primary care, I don't solely think about the four walls of a building. I think about this in more of a holistic and comprehensive way. And I think about it in terms of meeting people where they are, meeting people where they enter the door or the space, meeting people where they're most comfortable, and really thinking about it more in a people-centered kind of way. And in our state in Louisiana, I do believe that I don't believe there's necessarily true systems of care. However, there are pockets of innovation and models that I can kind of share that kind of gives examples of this primary care anchored kind of model. So for example, for individuals with serious mental illness in our community across Louisiana and in many regions across Louisiana, oftentimes the doors that people with serious mental illness are entering first are a community behavioral health organization. And we have many examples of these entities who are not solely just providing, mental health and addiction treatment. However, they're providing holistic care to people who walk through their door. We actually even have examples of some community behavioral health organizations who also have federally qualified health center designations because they really wanted to provide a holistic frame to their patients, as well as partner with other organizations to help create a holistic plan for individuals and not just addressing their healthcare needs, but also addressing some of the social needs that you kind of talked about earlier. I also want to highlight another example that we're seeing in our rural communities across the state of Louisiana, because sometimes, especially for those of us who live in urban areas, can sometimes forget that things are a bit different. However, they can do a lot with a little. So in our rural communities, one project that we're working on actually at LPHI is a project that's funded under Robert Wood Johnson Foundation that's really tailored to working with about 10 communities in the Delta region of Louisiana. And those are the regions that are actually along the Mississippi Delta on the Louisiana side. And this project is focused on reducing tobacco use, however, using a holistic perspective. So we're bringing in folks from community-based organizations, as well as rural health centers to work together to provide both traditional and non-traditional types of services to address the holistic needs. In this case, it is tobacco, but obviously people may enter into a community-based organization and these folks don't have providers. They can talk about cessation and refer them to the rural health centers and vice versa. Rural health centers can provide information and help, get folks the cessation resources that they need. So those are just a couple of examples, I feel, in just even our small state that I can kind of draw upon.
Oh, that's great. Thank you. Charlene, what would you say about examples of primary care anchored systems?
Yeah, I love those examples. So I'll start with one example, which is actually for us, it truly is a statewide system. We are in the midst of undergoing Medicaid managed care transformation in North Carolina. And we were very fortunate to be able to build upon a primary care infrastructure and a framework that was really run by an organization called Community Care of North Carolina, which really did a lot of community-based care management, and that we built upon that in Medicaid transformation and have a concept or a vehicle for really doing this primary care anchored whole person care, our whole Medicaid transformation is really all centered around this concept of whole person health, which is just fantastic. And so when we say advanced medical home, what that means is that it is, like a patient-centered medical home, but advanced in a couple of ways. One is that when we think about the care management responsibilities that these advanced medical homes have, the expectation and also the tools that are available to do that more holistically, so that we're not just thinking, oh, this child has asthma, we need to provide care management for that kid's asthma, which is like their medications, but it's also thinking holistically about what's going on in their home. Oh, are they also food insecure? What can we do to help there? And because we recognize, I think, Shelina, like you were saying, right, there are going to be some primary care practices, those in our urban centers, those that are large, those that are attached to academic medical centers, right? They have a capacity that looks very different than some of our much smaller practices, some in urban areas, but certainly many in our rural areas. And so part of building this primary care anchored system was building a tiered glide path in this advanced medical home model, so that there was an opportunity for lots of different types of primary care practices to be involved, from those that don't really have a lot of, say, that data infrastructure and capacity that you would really need to do some of this population health work, all the way up to the mega practices or the big practices affiliated with our big academic medical centers, like I'm at Duke or at UNC, that have really big academic medical centers. And so as we think about the advanced medical homes, they're doing data sharing, they're doing care coordination and management support, and there are a lot of supports around the primary care practices so that they can participate. One example, and I think I'll come back to this a couple of different times, Shelina, interested if you guys have some sort of similar platform in Louisiana, is, for example, we have a platform called NC Care 360, which is the first statewide coordinated referral platform to make it easier for those of us in primary care, when we identify these needs, to be able to use this technology platform that has all of these other providers on there, right? These other partners, Shelina, that you mentioned, that we know are outside of our clinic walls and that we need to be able to partner with to really address whole person health. And so we have this NC Care 360 system in North Carolina, so that when I see a child and I recognize that they're food insecure, they have some housing instability, there's a platform where I can put referrals in, and then there are entities on the other end, food banks, housing providers, who can then take that referral, pick it up, say, I can help that child. I'm near where that family lives, and then I can find out that in fact that referral was picked up and that need was met. And so I think that is one statewide system that's really primary care anchored, that is aiming to do whole person health.
Yeah, I mean, I think all of those are really great examples. And one of the things that they talk about is like that first of all, there should be no wrong door. Like wherever you walk into the system, you ought to be able to be picked up. I don't think that's true for many people in our systems, but whether it's Medicaid or Medicare or frankly commercial insurance or people who are uninsured, it doesn't really matter. It's actually sort of a hard thing. But I think this idea of sort of integrating around primary care is really important. What do you think are the sort of I guess I would call them movable obstacles to creating these kinds of primary care focused whole person systems? I mean, to create a statewide referral system like that, takes a lot of resources and takes a commitment. But then there has to be sort of a catcher's mitt on the other side, right? The primary care providers have to use it. The social service providers have to use it. How do you think about these sort of the capacity building and the movable obstacles, I guess I would say, to sort of creating those systems? And where do you see the sort of the sweet spot of where we think we can move forward in this next, very, specific period in the next 5 years or so?
Well, I guess I'll jump in first on this one. I think, because we were talking about integration and, if we're really going to do this concept of whole person health, there have to be these data systems. And, I gave an example of NC Care 360, which is really on the addressing when there are unmet needs by having this resource referral statewide platform where, Louise, you're exactly right. You have to have enough users on both ends of that, the people putting the referrals in and the people to catch the referrals when they come out. Obviously, we also need resourcing that are coming to the people who are catching the referrals on the way out. because part of what we've done also in Medicaid managed care is instituted universal screening with a standardized set of social drivers of health questions, which is, again, really important because we want to know who has these unmet needs. We don't ask often enough, I think, in not only primary care, but we have really tried to create in NC Inc. this idea of a no wrong door approach, because for children, especially our teenagers, sometimes they're not coming to primary care, but if they're going to school or if you've got a young child in an early care and education setting, right, we hope that they're getting screened, and they often are, for these sorts of needs, and being able to bring all of those data together. So I would say certainly there are data systems that are a movable barrier, because that technology certainly exists to be able to have that type of platform to do these referrals. And I think on the front end of all of this, being able to bring data together that we actually already have in a couple different systems, right? For kids, we're thinking about Medicaid as a key payer. We're thinking about schools. We're thinking about early care and education, child welfare, juvenile justice, right? All these systems that are sitting on a ton of administrative data that could help us to identify within primary care, who is it that we really need to be making sure we're reaching out to, because we want to find those children, those adults, individuals who are at that rising risk, so that really the efforts that we have are going to have the most impact. I'll just say one other one, and then Shelina, I'm so curious to hear what you have to say too. I think another movable barrier is we have to fill in insurance gaps. It is really hard to access primary care when you can't afford it. We in North Carolina are one of the states that has not expanded Medicaid. And so we have a lot of adults, and we have and still too many children who don't have insurance coverage. And so I think that is another movable barrier, is to get more people health insurance coverage so that they can access high quality primary care, as well as the other integrated services around that.
So interesting. A few of the things that you brought up, or a couple of things that you just named, I named, but in an interesting way, because in the state of Louisiana, we have expanded Medicaid. And so now I believe only 8% of our individuals do not have a health insurance. So 92% of individuals in Louisiana are covered by some form of health insurance, because we expanded Medicaid in, I believe, 2018. However, just because Medicaid was expanded and people are now insured doesn't mean they're going to go to care. So one of the things I know, a big obstacle is really, how do we provide opportunities and change social norms around going to a doctor in a culture, in many cultures around Louisiana, where like seeking care before you need it is a thing, like is the behavior. I was also excited to hear, Charlene, about your NC Care 360, because I know that is a model that we often reference here in Louisiana. So at LPHI, we actually operate a health information exchange for the greater New Orleans area that we're trying to expand beyond just New Orleans. And we would love it to be more robust, to cover exactly what you're talking about. The referral networks that are not just within healthcare, but actually in New Orleans, we do have connections with the Orleans Parish jail system, for example. We have connections with social services providers, as well as hospitals and primary care providers, so that once someone is hospitalized or in an ED or inpatient setting, the notification gets sent to the primary care provider, and then that notification, once that person hits the primary care provider, the notification is sent back to the hospital. I mean, that's just a simple notification. We would love it to be more robust. So I actually indicated as one of those obstacles that could be removed is, how can we use that and put it on steroids? How can we use those systems of referral networks for the entire state? And I know we're in conversations with the state to kind of talk through that. I think funding resources are the biggest kind of barrier to making that happen, because the data is there. We just need those connections and the funding to do it. And I will also share the piece that you mentioned about universal screening. I think is key. I feel like one of the key obstacles is that we have evidence-based models. We can standardize care, and it's in our state. I think there is a move towards doing that standard of care. However, we're seeing time and time again in certain health outcomes, and I can talk about this a little bit later, especially when we're talking about maternal mortality, that care isn't actually being standardized, even though we know there are standards of care in certain areas. So I think that's also an opportunity to help to help improve health outcomes.
I think one of the tricky problems is that it's always, even from a local foundation to a state Medicaid system all the way up to CMS, it seems like it's easier to fund a pilot than it is to fund the spread of substantiated good practices into the whole system. And I think that the new CMS director has talked about that as one of the things that she would like to address. And I think that is that to me is one of the obstacles that I think we face, is that we're sort of in a little bit of a moment where we say, well, we'll just do another pilot. And sometimes we actually know what we need to do, but it's much more expensive and much harder to actually spread the right practices across the state. So that's one of the reasons why it's exciting to hear at the statewide level or even at a citywide level that there are some really great practices that we can think about how you meld primary care with some of these other systems. I want to move on to.
Can I jump in? Sure. Because I also wanted to bring up, it made me think there are some barriers. It's not just for primary care, but it's just for healthcare in general. And I think as we're thinking about, a whole person, primary care focused system, COVID has really brought to light some true barriers that I think we knew these existed, but as we're trying to roll out COVID-19 vaccination in North Carolina, across the country, I think there are other barriers also that we need to really think about for a more equitable primary care anchored whole person focused system. So I'll just name two that we've worked really hard in North Carolina to try to move the needle on. And I think we have during COVID. One is language access. Our healthcare system is incredibly complex for people to navigate, even just into primary care, right, can be complex. And then you add on top of that an individual or family who is non-English speaking. And it makes it, in some cases, it seems like it's a virtual impossibility that they would actually figure out how to navigate into getting into primary care and being able to follow up on sometimes the still pretty complex things that we recommend, even within primary care. And certainly as we move into more specialized care can get very complex. So I would say that's one barrier that feels very movable. Again, I think both with investment in staff and workforce as interpreters, community health workers. Obviously, again, technology can play such a role. As in my clinic, we have these little screens that can roll around so that you're not having to just do the phone, but you can actually see someone who's speaking in almost every language. I've never had a patient who's had a language that our little video interpreter couldn't access. And then the second I think that's so important is also transportation. Because again, one of the joys of doing primary care is sometimes we say, I think it's okay. Let me just see you back in a couple of days, or let me see you back next week. Well, it's really hard to do that when you don't have the transportation that you need to be able to actually come to the clinic. And this is something we really worked on hard in North Carolina, because again, we were trying to promote equitable access to testing and vaccines and treatment for COVID-19. We were able to forge some new partnerships for thinking about how to provide transportation so that folks could access those needed services during COVID, and certainly thinking about how we can really continue to lean into some of those new relationships and partnerships as we recover from COVID and try to create more of these whole person systems that are really integrated with primary care.
I think it's interesting. I mean, I think that the COVID-19 pandemic and the emergency that it sort of caused has created a situation where a lot of things that all of us thought around the country couldn't happen because the regulatory framework was too strict, or we couldn't figure out how to, contract or whatever, that a lot of those things really have changed. And so it does beg the question, I think, for can we keep the things that really worked? To me, a movable obstacle is really like, let's modernize our regulatory framework. And let primary care do the things that it needs to do, because those are the low cost things, right? Sending someone to a primary care provider by a ride sharing service, for example, is a lot cheaper than having them go to the emergency room. And so we just have to learn how to do those things, be willing to take that stand that in fact, yes, there's a cost to it, but the actual cost is much less than the other outcome, which is someone waits until they need emergency care and then they go to emergency room. We know that primary is generally, there are fewer primary care providers. A lot of them have retired. This has been a tough moment for a lot of primary care providers, the COVID pandemic, and has sort of accelerated, I think, some of the retirements and the folks going out of the workforce. So how do we make primary care really an attainable and attractive, a sustainable career choice for a larger and more diverse cohort of not only medical providers, but for social workers and for community health workers and for a whole set of people that we know really matter in terms of doing that kind of team-based care. What is it that we need to do to sort of shore up the workforce?
So, I mean, I think for this question, I kind of think about my own experience. I was someone who grew up with a father who was in healthcare. He's a pharmacist, although he was one of the only folks within our family who even went to college. And then I went to a historically Black college and university here in Louisiana that was specific for folks who were very interested in the allied health field, like pharmacy, pre-med. I went to Xavier University of Louisiana. And I just feel like we must look at the pipeline, and it can't start within undergrad. Like the pipeline has to start much earlier in a person's life from like childhood. And how are we investing in providing those opportunities and exposure, particularly to people of color, Black, Indigenous, and people of color, to let them know, A, that it's an option for them if they're not seeing it within, their own communities, B, to help incentivize it, because it's not inexpensive to take the exams that is required, to go interviewing if you're a physician or those allied health professions that need that, to take classes to prepare, like to take the test prep. All of that costs money. And so I feel like, if you can let folks know from when they're a young child and then help support them financially along the way to get into these careers, I think that will help. I do feel like there are, HRSA has the loan repayment programs for certain professions, not all. I'm a public health social worker, and it's still a little bit, weird for me not being in clinical practice. So that's a whole other issue because I'm not a direct service provider. I feel like there needs to be even more, greater loan repayment for folks who are not clinical, who are working kind of at the intersection of public health and primary care. But I think there are some things out there, but I think more needs to be done with the pipeline starting at very, very early ages.
Yeah, Shelina, I totally agree. And I think when I think about the pipeline, it's really so much of that is about mentorship, right? I mean, the value of an amazing mentor just cannot be, you can't put a value on it because it is really invaluable. And so I think it's another thing to also incentivize and provide funding for early mentorship. And I agree, Shelina, it's got to start really early. And once you've got folks who are actually in the physician medical training pipeline, there also needs to be opportunities and funding for primary care leadership development. And that's by the medical schools, the health systems, and again, not just for the students, but also for the faculty who are going to be, taking time away from their clinical time when they could be making money, and counting their RVUs, but really providing funding so they have that protected time to do that work. I wanted to raise two other sort of, different topics that I think are really important to think about when we want to think about how we can make primary care more attainable and attractive. We have to talk about the economics, right? The salary equity between primary care physicians and our specialists it's just way too wide a chasm. Certainly the way that payer reimbursement, we are not seeing equity across payer reimbursement. So for example, thinking about what could be done in the Medicare physician fee schedule to help right size some of those reimbursement inequities. And then I know we'll get to this more later in the conversation, but as we think about the economics and what are the payment models, not just payer reimbursement, but really moving towards more advanced value-based payment models, these alternative payment models that facilitate the type of flexibility that we need as primary care providers to actually spend our time doing the things that we know that really matter. So we can get out of this fee for service, like needing to check all these different little boxes, when we actually know that what's really important for our patients are some of these other things for which there is not a code to bill on. And so thinking about the economics. And then I think the second or the third thing, in addition to the pipeline, the economics, I think the third is it's really hard, Louise, as you said. And I think primary care docs more than ever are just super burnt out. And so when we're thinking about how do you make this an attractive and a sustainable career, we really have to think about how is it that we as a system can reduce some of these friction pain points that primary care providers are feeling, because people are burning out. They're resigning from their primary care roles that they've played for years, decades, because it's just gotten too hard. And there's so much time that's spent doing these things that aren't the things that we went into primary care for in the first place. So I think we can't not say something about just what the day-to-day workflows look like for primary care providers, physicians, as well as the whole team that is working alongside the clinician.
And Charlene, that's what I wanted to step in and say. I mean, I appreciate primary care physicians, and there's a whole slew of individuals who make even less money in primary care, social workers, nurses, the medical assistants, the community health workers that we definitely have to be thinking about in terms of their sustainability, and even being part of that group of individuals that they're trying to serve, like, especially if we're talking about the safety net. Many times, often, people who are providers who may not be the physicians are part of the communities who may be struggling and living paycheck to paycheck. And they're also trying to help serve people who are living paycheck to paycheck. So how are we kind of addressing those economic issues as well for folks who are part of that entire primary care team? Physicians and social workers, nurses, MAs, community health workers, and the like.
I think it's always interesting when we talk about sort of primary care and the need for investment, and there's always inevitably someone in the audience that says, well, are you just saying we should pay providers and people more? And what I say is, you know what? I think that's part of what we do. Absolutely. We pay them more. And then we also pay for the conditions for them to work better, that we pay for the IT systems, that we pay for enough staff so that that there's team-based care, so that we pay for, to your point, Charlene, about sort of the friction points for providers, that we get rid of a lot of the unnecessary reporting that really is not adding value to a patient encounter, to someone's health care, but is really being done for insurance purposes. And sort of, those are all things that we need to be thinking about, because those are the things that really will matter. So it is about pay. It's not, that's not irrelevant. But it isn't the only thing. And I think sometimes that conversation gets lost. But I think it's also important that we think about specifically things about, as you were saying earlier, ways in which we can really change the workforce so that it does, in fact, reflect the communities in which that they serve. And so I think really thinking about national programs and state programs to incentivize, as you say, people to go into those those professions, and all of the team-based care, and to really think through rewards for going into primary care. But I think there's some motion in that direction, but it's still slow going. So I think the next topic that I wanted to just talk about is sort of this idea of sort of community planning, and thinking more about sort of how communities work on the ground together. One of the things about all of our worlds is that, there still remain significant silos, even though there are great things like the sort of referral network that you talked about, Dr. Wong, and sort of some of the sort of ways in which you're thinking about sort of working in sort of an overarching tobacco program in Louisiana. But, generally community-based planning, health planning, social service planning is done in silos. So social services plan what they do, and education plans what they're going to do. Healthcare plans, by system, not even sort of as a whole. And I think the question is, how do we think about how we direct investment to those efforts where they're really trying, at that core to say, these are all the services that a community needs. We know that some communities need more services than others, and yet it's really not where most of our services are located. So, we all know that community redlining, a practice by the banks in the 1930s to sort of drive investment or drive disinvestment to communities that they felt were unable to sustainably take on debt. It turned out that those are the poorest communities, mostly the communities with the largest population of Black folks. At the end of the day, those things that happened in the 1930s remain today. So the communities that were redlined in the 1930s still remain the poorest, the sickest, that have the worst outcomes. And so couple that with COVID, which also laid bare, I think something that all three of us knew before the pandemic, and a number of people sort of learned during the pandemic, was that there are enormous health inequities and health disparities that exist in communities, that the worst morbidity and mortality for COVID was in communities that had fewer primary care providers to begin with, and these were largely communities of color, much more low-income communities, that the delayed care due to COVID is substantial in those communities, and that the cost of care is a big driver for those communities. So that was a major issue. And I guess my question is, how do you think about sort of place-based investment? How do you think about, like, how do we do work in communities to make sure that we're not just enhancing the silos by helping them develop better, but really saying, like, at the community level, how do we bring all of that investment together sort of in some melded way? I think it's a really big challenge. I don't know that there are some great examples that we could point to, but I'd like to know how you think about it, and if you think there are examples in your state or elsewhere that point in a direction that we could go, that isn't only planning, but it's connected to action. So, Dr. Wong.
Yeah, so I'll give an example because, like you said, Louise, this was very apparent during the COVID-19 pandemic. And in North Carolina, we were very committed, as we have been for a long time, to lead with equity. And so we actually, a specific example is that we have a really exciting initiative that is active now, boots on the ground, called Healthier Together. It's a health equity action network. And it was really initially started because we knew that we had a lot of work to do if we really wanted to equitably and quickly vaccinate as many North Carolinians as possible, particularly those in our historically marginalized populations, who, Louise, as you point out, had a lot of really good reasons to not trust messages that were coming out of public health agencies, from the government. And so in that commitment to maximize both the speed and the equity of getting these vaccines out to North Carolinians, we really built, it was a grassroots mobilization strategy. And it was very much centered on building and earning trust. This was, again, like I said, boots on the ground, regional teams, working with community partners. Because actually what sometimes we found out is you might think that there weren't those resources in those communities, but when you have the people from the community who are really going out and finding out what local resources are available, it turns out actually that there are often resources available there, and they are really able, ready, willing to come and partner to help improve health and well-being, particularly during the COVID-19 pandemic. We just saw so many public and private entities really step up to the plate. And it took this sort of really grassroots organization so that we could build the trust, because sometimes we were asking healthcare providers, local health departments to partner with a church or a community-based organization that they had just never worked together before. They didn't know about each other before, or minimally so. And so really doing that hard work to both build that trust and those relationships, and to co-create the strategies in collaboration with each other. So they were building things that were going to work in their community. And then using data to really validate and see where things were working, where we needed to continue to tweak things and learn as we go. And so I think Healthier Together is a really great example of something that was born out of the pandemic, and that is really now being used to lay even additional groundwork and foundation for building further health equity in North Carolina.
It's so interesting, Charlene, because that's a similar example that I was going to provide. And I think I'll give a little tweak too. So, with our work, and we are not the state health department. However, we work very closely with our state health department. And we have a campaign that is the Department of Health's campaign called Bring Back Louisiana, that LPHI is really working behind the scenes on one particular component, which is that grassroots component. And how it actually, even the grassroots component kind of came to be, is that we had community organizer organizations who do things like get out the vote, other kind of community, neighborhood, door-to-door outreach. And they came to us as the Public Health Institute, and they were like, we need to do something before vaccines even hit the scene. They were like, we could be utilized. Our infrastructure of faith-based leaders, of community organizers, of rebel rousers in communities across the state of Louisiana can be used to help get the vaccine out and to help give folks the science-based information and the facts about the vaccine. But we just need training because we're not health people. So they came to us and they're like, can we be connected to the state? Because these aren't organizations that typically even want to work with government. They're like kind of anti-government, but we are that intermediary. So we helped to kind of broker those conversations with the state health department. And here in New Orleans, the health department was already kind of doing some of that same grassroots stuff. And we said, yes, we need data, but we need it quickly. And it's not going to be perfect, but we need data to see what's working. And what has happened over time is that we've brought together like 30 plus organizations from, the United Home and Nation, which is a federally recognized tribe, to mutual aid funds in the Bayou, to rural areas in Southwest Louisiana, to North, like folks who are of the community going in, being trained. We've been training them on COVID-19 vaccines. They go door to door. Sometimes they have shots in hand with a mobile clinic that was a partner from an FQHC or a hospital system, so that if people are like on the fence and we say it's right there, they will get the shot in the arms. And, that just came out of interest in wanting to do like the good. And I feel like, even to Louise's point, that kind of those non-traditional types of ways to help support community need to start being funded. I mean, obviously out of COVID, they were funded, but I feel like those types of like kind of organic relationships and cool things to do quickly could, prove to be a really good thing to invest in.
So Shelina, it's so interesting you said that, because our partner organization that's working on Healthier Together, it's NC Counts Coalition. So they've been involved in like Get Out the Vote. So it was that same sort of infrastructure, right? It was already existing, and they thought about how they can leverage that. And I think, again, the real opportunity, as you said, is there's been a lot of that work on the ground, because it takes time, right, to build that trust, to build those relationships. How do we sustain, right? We have earned the trust. How do we sustain that trust, which is going to involve resourcing? And I think making sure that primary care practices are really plugged into that as well, because obviously at least in North Carolina, our local health departments have done an incredible amount of work during COVID and partner and serve in this very important role in their communities. And how can we also now bring some of those types of partnerships to our primary care providers, who also have played an important role in vaccination and in the COVID-19 pandemic, and continue to build that sort of more integrated system that we keep coming back to.
That's interesting that a pandemic sort of opened up opportunities. It sort of opened up what the problem, we sort of learned a little bit more about, or everyone else around us learned sort of some of these problems and these barriers. But then it enabled, I think this interesting, what you both talked about was this idea of like how civic engagement organizations who are sort of designed around that really can partner with primary care and public health, obviously, to sort of push forward some of these messages. And I wonder if you all think that can be used for, tobacco, as you're working on, Shelina, and if it can work for hypertension, if it can work for sort of a lot of these other things that require both, people to be informed, people to take steps, but also then requires kind of the healthcare system to be there and ready to work with them as they kind of come in the door. I think that's a really interesting, relatively new phenomenon that I think COVID really showed us. And I think that's true around the country that this happened. But those are two really great examples, really interesting.
And can I also just jump in too? I think, and one thing I wanted to mention, the impact of us really, again, it was centering equity in the work that we were doing, because we were really touching on people who consistently get left out on the margins. We actually have seen, I think Louisiana is the only state where people of color have a higher vaccination rate than white people in our state, because of our intentional efforts. That also shows some other kinds of things that we need to address, but I feel like we were very intentional around the distrust that we continued to hear and see from surveys that we were doing, like phone surveys that we were doing even pre the COVID vaccines, to see, where the hesitancy or unwillingness was coming from, and really using that data to inform how we, went out to community. Engaging civic organizations where by design, their work is truly about truly community and the people. And it's all about building trust. We have to, I feel like that was the core of public health, at least my disciplines, public health and social work. That was at the core of why these fields existed. And I feel like we need to get back to that for public health, social work, primary care, get back to that.
And today I was going to add on to that, because you touched on, so we actually had a multi-pronged approach, but you could organize them into 3 buckets when we were thinking about what we were doing to promote equity. And the first is this earning and sustaining trust, which I think we have talked about, all the different strategies, and that could certainly be adopted and, expanded into primary care more effectively. The second is we really thought about how we could embed equity in our operations, from how it is that we set expectations for our healthcare providers to the way that resources like vaccines or monoclonal antibody treatments are allocated out, to where we place, these sites and where we place primary care sites, right? Where we put these points of access, how we provide transportation. So there are a lot of different aspects of that second piece, which is embedding equity in operations. And then the third that you were just touching on that made me think of it, Shelina, is how is it that we share accountability for the equity work that we're doing? And so for North Carolina, we had efforts, very intentional efforts around requiring the reporting of race and ethnicity data. We did very intentional analyses looking at geographic data and looking at social vulnerability index data so that we could see, where we needed to do better, which has also helped us then to focus the efforts of our programs like Healthier Together, so that we knew that we were sending these boots on the ground to the places where we had the biggest equity gaps that we were really trying to close. And I think that I just want to harp on that data piece for a second there, because certainly if we are going to do more equitable primary care, we need to have the data that's going to allow us to know how we're doing and monitor, hopefully, how we're improving over time. And I'll just say, particularly because there is a lot of work to do in the racial ethnicity, area, making sure that the source data we're using is really good and is self-identified as much as possible, which is hard, to do. But, how can we get that better source data? And then how do we ultimately, and this is going a few steps ahead, but in primary care, how do we ultimately use those data to link into performance metrics and payments? So that, again, really thinking about building those incentives in to the care delivery and payment models that are on top of primary care.
Big challenges. And I think to the extent that, again, we were able to sort of do some of those things and really push those concepts forward in COVID response and resiliency, my hope is that we'll be able to think about that. And it won't be such a difficult concept to sort of say, well, how do we do our regular daily work? How do we think about that for all kinds of things that were chronic disease or other prevention activities, so that we're really using that construct, going forward. So for my last question, I want to kind of go back to this idea that you began to talk about a little bit, Charlene, which is that primary care, for all the work that we're trying to get it to do, gets about 5 to 7 cents on the healthcare dollar. Medicare as a whole spends about 3 cents on the dollar. And we know that social services get a much smaller amount than that, not to mention behavioral health, which is also gets less than that. So I guess what's interesting now is that there's about 11 states that have created legislation or regulation to measure, for the purposes to define and measure what primary, how much primary care is actually being, how much is being spent on primary care. And then they've all got some formula to increase it. Some of them are increasing very slowly, 1% year over year increase expected by the various insurance companies, both on the public side and on the commercial side. Some say, well, our goal is to get to 11 or 12 or 14 cents on the dollar through a whole variety of mechanisms, whether including reimbursement, and then, as you began to point out, thinking about alternative payment systems, incentive payments, global perspective payments, a whole variety of mechanisms, so that when we actually begin to look at our system as a whole from an economic point of view, we're actually saying we're not only saying that we promote primary care, but we're actually paying for it. And it's become central to what we're doing. And we sort of consider this a rebalancing. New York is one of those states that has some legislation in process, but not actually yet, not actually passed. But I'd be interested to hear, and I do know that Louisiana, and neither Louisiana nor North Carolina are quite there yet either. But I'd be interested in your thoughts about, the idea of really, we have used this and other states have used this as a way to really talk about, what's important. We'll pay for the things that are important. And how do we rebalance our healthcare system to focus on primary care? And I think of primary care, writ large, primary care, including behavioral health, primary care, including, a lot of the social services, that's a big construct. And we need to be thinking about that it can't be done on 5 to 7 cents on the healthcare dollar. And as we reduce total cost of care by improving access to primary care and the quality of primary care, we know that we can reinvest those monies, or I believe we should reinvest those monies into the primary care system. So I'm just wondering a little bit about what you think that increased investment in primary care might look like, either in your state, and across the country, to sort of get to where we need to be, which, by most states is somewhere in the more, the 12 to 14 cents on the dollar. Wondering what your thoughts are about that.
Yeah, no, I think it's such a great question, Louise, and I hope that North Carolina certainly moves in that direction. I do think, these payment models and the way that we structure them is going to be really important, right? Primary care, we lose in the fee-for-service Lance ecosystem, right? Primary care is certainly going to lose. I think a key thing, and this is certainly true of the work that I'm doing on the North Carolina Integrated Care for Kids, or NC Inc. model, is as we've been asking primary care, because it is anchored in primary care, because we know that's such an important component to do some of these really hard things. They're saying, like, what we need, we not only need more investment, but we really need more investment up front, right? Like, we can't do all these things and then, because not like we have this capital that's just hanging out in reserve in our practice, right? To invest, to do these hard things. And so thinking about, of course, like increasing the capitation per member per month, whatever sort of the payment is, and doing that in a capitated or subcapitated fashion so that those dollars come in upfront. Because I think, again, if we really want primary care to be able to do this more whole person health, then we need those dollars invested upfront. I will say the second thing, and I say this because I think it's hard to think about, because we want more dollars to be invested in our primary care practices, right, within the healthcare system. We also know, when we think about primary care writ large, we have to think about how can we actually achieve this elusive blended or braided funding, where the dollars don't all just sit within our healthcare system, but also move out into the partner organizations that are helping us meet those unmet food, housing, transportation, interpersonal safety needs. Those happen to be the 4 areas that North Carolina has prioritized as key social drivers of health that are being universally screened for. When you think about doing that, you're like, okay, well, then you've got the however many cents on the dollar. And very likely, I think, as we're talking about having that distribution of funds into these blended and braided arrangements, it's probably coming from that same piece of the pie, right? And so really thinking about, needing to make the pie larger, making the slice of the pie bigger, also acknowledging that part of that pie is going to actually go out to new partners that haven't been part of the payment models in the past, I think is really important. And an example in North Carolina where we're starting to do that with our 1115 waivers, we have what are called the Healthy Opportunities pilots, where Medicaid dollars are being used to reimburse on a fee schedule for the types of services that we know are important in food and housing and transportation, interpersonal safety. And of course, we're going to be evaluating that to see, we really believe that it's going to work, and we want to understand how it works and for whom it works, and how we can make it even better and hopefully get that type of model to scale more broadly. But again, it's tricky because we're drawn from the same pie, same slice of pie, as we're thinking about needing those dollars also to fund our partners.
Yeah, I mean, I think that part of this conversation is really about saying, if we believe, and I think the evidence is really clear, that this kind of very broad approach to primary care connected to sort of the social services and behavioral health actually reduces cost. I think that's pretty well documented. Until we actually start that robust funding up front, we're never going to get to that cost reduction at the back end. And so there's that I think is part of, it's not only case management, right? It's a lot of other things that need to be provided. And so I think that I totally agree with you that this kind of upfront global prospective payments to primary care for taking care of a whole population of people, is really the way that we want to go, because otherwise the incentive is to see people. And we know that probably the people who are the sickest, and I would say, the least equitable primary care being delivered is to the people who aren't showing up in primary care. So if your whole payment system is designed around people walking in the door, then you've really created a situation that sort of duplicates the current problems that we're seeing. So I would agree with you about that, real need for that upfront prospective payment.
Like, as I was kind of thinking about this question too, I mean, as we've been talking about, Louise and Charlene, there are certain models or demonstrations that are happening, like with 1115 waivers or For example, even here in Louisiana and across the state, there's like the Certified Community Behavioral Health Center model. There's the FQHCs with prospective payment and, financing, like, doing value-based care. I am just curious at how do we fund not solely in those four, the four walls of a building, and how does that get funded? Because then it just gets super wide and broad, and that looks different depending on the area you're in. If you're in an urban or a rural setting, it also looks different in terms of what services exist, because we have many rural areas that don't have a behavioral health, like a specialist behavioral health, or they may or may not have a primary care provider in certain areas. So then, how do we, when there's not the people, the workforce, even if there is a funding mechanism, how do you then support that as well financially and create that system? That's what I grapple with, even when I'm thinking about this conversation and the question that you posed.
Yeah, Shelina, because, this idea of blended braided funding, right? It would be bringing healthcare dollars alongside whatever dollars are coming into some of these other systems. And it's just so hard to, get those arrangements created, so that we can actually really bring those dollars together so that all together we can be aligned on really trying to move the needle on these different measures of whole person health.
Do we think that thinking about primary care as a common good, beginning to talk about it that way, really with the lens of equity, I think in particular, kind of could really push forward this conversation about what do we expect in our communities? Do we expect every single person to be able to have access to primary care as a common good? And then what do you think, what do you think that might do to the way in which we engage in the conversation about primary care? Again, thinking about primary care sort of writ large. Do you see primary care as a common good or a social good? So I think we'll start with Dr. Wong, and then we'll be able to end with the words from Shelina.
Well, I think certainly right now, primary care is more seen as an economic good rather than a social good. And there is no question that the system now is broken, right? We've got high and growing costs. We certainly have relatively poor outcomes when we compare ourselves to other countries that spend much less than we do on healthcare writ large, but certainly have very strong primary care systems. And when you have our health system as it's set up now with primary care and the rest of healthcare as this economic good, you just get this, like, as I mentioned before, super complicated system. People are very confused about what services they can get, no idea how much it's going to cost them, sometimes certainly leading to people choosing to not seek care because they are worried that it's going to be costly, because it often is. I think when you think about health, primary care as a social good, because certainly thinking about it as an economic good is not working for us. I think, you can certainly look to some of our other countries that have more arranged their system with primary care and healthcare as that sort of social good. I'm thinking of places like the UK and Scandinavia. And certainly when you're looking at the types of outcomes that we want, right, the better health outcomes at a lower cost rate, achieving this concept of value, you do see in these countries that they've got better ratios when you look at that value equation than we do in the US. Now, not to say that's all a panacea either. Obviously, there are things that they are trying to also reform and transform within their own healthcare systems. And again, COVID has brought to light things that were working and not working in their systems, as it did for our system here in the United States. But at a bare minimum, I can say that treating primary care as an economic good is not working. And so we need to do something different.
Oh, great. Well, thank you. Last words from you, Shelina. What do you think?
Completely agree with Charlene. And I think philosophically, I truly believe primary care is a common good. I think, and I'm going to put a spin on value-based, we must start treating every human being as a valuable human being. And then if we actually truly were honest about that, then we would actually start seeing improved health outcomes. And I feel like then everybody would believe it wouldn't be an economic good for primary care, but it would really be us thinking of primary care as a social good when we start treating every single human being as a human being and valuing them truly. In I know not the definition of value-based care, but in terms of how we value each other as humanity.
Yeah, I think that's really well said. So I guess I want to thank both of you for this really thoughtful conversation. I think you brought us some really terrific examples about how we could move forward. I think you've raised some ideas about things that we could do better. And I think you've kind of put up a vision of what the future could look like if we really had a primary care anchored healthcare system that really was expansive and worked well for the communities that we're serving. So I want to thank you for your time. I want to thank you particularly for your approach and your thoughtful comments about health equity and how we might get there. So with that, I think we'll bring this program to a close. I want to thank our sponsors that made this possible, and as always, to our PCDC staff and board who work with all of your staffs every day to try to move this work forward. So thank you. We'll hopefully talk to you soon.